Hello. 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 Hello.
Hello.
Hello.
Hello.
Good evening, everyone. Welcome to Uveitis Symposium. We'll be discussing about anterior uveitis today. I'm Dr. Madhu Chirantan. So, what is uveitis? Uveitis is a common sight-threatening inflammation of uveal tract, which is comprised by the middle pigmented and vascular layer of eye, including the iris, ciliary body, and choroid. Uveitis can be classified in different ways: anatomically, clinically, etiologically, and pathological classifications. Among that, the Sun Working Group has given anatomical classification, which divides into anterior, intermediate, posterior, and panuveitis. Anterior uveitis is the inflammation of anterior chamber affecting the iris and anterior ciliary body. The conditions, it can manifest as iritis, iridocyclitis, anterior cyclitis, and pars planitis. Intermediate, in intermediate uveitis, the primary site of inflammation is vitreous, and it can also include pars plana. So the conditions may be pars planitis, posterior cyclitis, and hyalitis. The posterior uveitis is the inflammation of retina and choroid, and it can manifest as focal or diffuse choroiditis, chorioretinitis, retinochoroiditis, retinitis, neuroretinitis, and retinal vasculitis. And panuveitis includes all these compartments. Coming to our topic, anterior uveitis, it is the inflammation involving the anterior uveal tract, that is the iris, and the anterior part of ciliary body, which is pars placata, and it is most common form of uveitis. Acute anterior uveitis is most commoner than chronic type, of which HLA-B27 and idiopathic make up the largest proportion of diseases. So when we are diagnosing, we should consider the idiopathic factor too. And anterior uveitis can clinically classified into acute, recurrent, chronic, and remission type. Acute uveitis is sudden onset, unlimited. Limited means it lasts less than 3 months, and recurrent uveitis is there are episodes of disease with inactive, untreated period of 3 months. Chronic uveitis, the inflammation is persistent, the disease lasts for more than 3 months, and the relapse occurs within 3 months if the treatment is discontinued. In remission, there is a period of inactivity for at least 3 months. Pathologically, uveitis is classified into granular matters and non-granular matters. Granular matters uveitis is gives the circumscribed lesions with focal reaction and a typical mutton fat KPs with thick and coarse iris adhesions. In non-granular matters, the lesion is diffuse with diffuse reaction, fine KPs, and thin and fine adhesions. Coming to the symptoms, the patient may come to us. Anterior uveitis patient comes with pain in acute cases, and chronic cases the pain may be mild or even the patient may be asymptomatic. In diminution of vision is mostly a feature of chronic uveitis than acute. And other features include redness of eye, lacrimation, photophobia, and halo surround light. On examination, in a case of acute uveitis, we can find circumciliary congestion, fine keratic precipitates, AC cells, endothelitis, Kopes nodules, hypopyon, acute rise in IOP can occur, focal posterior synechiae can be seen. In chronic cases, there might be mild or no congestion. Mutton fat KPs are features of granulomatous uveitis. Broad posterior synechiae might be formed, AC cells, meiosis, IOP changes can occur, iris nodules can be seen, band-shaped keratopathy, pigments can be formed over the anterior capsule, and cataractal changes, iris atrophy, and finally the eye may go into phthisis. This picture is a comparison between acute and chronic. Like I said, in acute there is circumcorneal flush, which is an important feature, and the fine KPs are fine compared to the chronic, where there is mutton fat KPs with relatively large sized nodules, and there is band-shaped keratopathy with cataractus changes. Coming to these signs one by one, circumciliary congestion occurs due to iris and ciliary body inflammation, resulting in dilatation of these vessels. Congestion in anterior uveitis is typically circumciliary, which needs to be differentiated from acute red eye, where the congestion is diffused. Another important finding is AC cells and flare. Exudation of inflammatory cells in tissues. These inflammatory cells leak into anterior chamber, and they are seen as aqueous cells on slit lamp. In the chronic leakage of proteins due to breach in the blood retinal barrier, they result in something known as flare. How do we see them? The cells or pigments in the aqueous humor reflect the light like a faint fog. To visualize them, we in the slit lamp, the slit illuminator is adjusted to the smallest beam and is projected through the anterior chamber, forming a 40 to 60 degree angle. We should use the maximum magnification and no filter should be used. And the size is 1 cross 1 mm beam. What we see, we can see WBCs, RBCs and pigments. WBCs are relatively large cells compared to RBCs, and they appear white. RBCs appear reddish and reddish brown cells. Pigments are smallest and fine. The Sun working group has classified, has graded the AC cell into 5 categories. In the field size of 1 mm by 1 mm in slit lamp, if we are able to see 1 to 5 cell, it is graded as 0.5 plus, 6 to 15 is 1 plus, 16 to 25 is 2 plus, and 26 to 50 is 3 plus. And more than 50 if we are seeing, then it's called 4 plus cells, and the disease is described into if 1 plus, faint, moderate, marked and intense based on these grades. Coming to another important finding, keratic precipitates. They occur due to reduction of nutrition to corneal endothelium because of toxins. These corneal endothelium becomes sticky and it becomes edematous. The desquamated cells and inflammatory debris gets attached to the endothelium and they form precipitates over cornea called as keratic precipitates. They can be fine or mutton fat. The new KPs appear circular and compared to old KPs which appear crenated, and they organize themselves in a triangle manner, which is given the term called Arl's triangle, which occurs due to convection currents which happen in AC between iris and cornea. And stellate KPs are seen in Fuchs uveitis syndrome. In this picture, we can see the KPs organizing in a triangle manner. These are basically mutton fat KPs. Another feature is hypopyon. In very intense cases, the polymorphs pour out and sink to the bottom of anterior chamber. They can be mobile or non-mobile. And black, specifically black tinged hypopyon is seen in herpetic keratouveitis, and hypopyon in a white eye, which is mobile, is seen in Behçet's disease. Meiosis can also occur in anterior uveitis. It occurs due to exudates cover the iris as a thin film and they spread over the pupillary area, which causes irritation of iris musculature. And the constrictor muscles being more powerful than the dilator, the eye goes into spasm, causing meiosis. What are the iris changes which we can see? Due to inflammation of iris and ciliary body, there is dilatation of blood vessels, there is iris stromal edema. So the iris pattern gets altered, the color changes, and iris becomes thickened. And in the granulomatous stage, we can see nodules. If they are seen in the pupillary border, they are called as Koppe's nodules, and in the periphery they are called Berlin's nodules and Basaka's nodules if they are coarse. Posterior synechiae. In early stages, there is adhesion of iris to lens capsule, and these iris pigments deposit on the lens capsule. Later on, they organize and form a fibrous band between the pupillary margin of iris and the lens capsule, which forms posterior synechiae. And posterior synechiae is more common in lower part of the pupil due to gravity. And there is something called festoon pupil. When the adhesions are localized and we instill a mydriatic, it causes intervening portions of circle of pupil to form a festoon shaped pupil. This occurs due to irregular dilatation and is a sign of present or past iritis. And as the iris bulges forward and it comes into contact with cornea, adhesions of iris to the cornea at periphery, they develop and give rise to a sign called peripheral anterior synechiae, and which causes the angle obliteration. So we can see rise in IOP, which leads to secondary glaucoma or hypertensive iridocyclitis. So in this image, we can see the peripheral anterior synechiae which has formed. So the next change is total posterior synechiae. The exudates fill up the posterior chamber. If there is much of cyclitis, then when these adhesions organize and they gets adhered to the lens capsule to give total posterior synechiae. And when these recurrent attacks happen, or in severe cases, the whole circle of pupillary margin gets tied to the lens capsule, forming a ring-shaped synechiae, which is called ring synechiae, annular synechiae, or seclusio pupillae. And the aqueous starts to collect behind the iris. Since the aqueous drainage is hampered, the iris bows forward like a sail, and which is seen as iris bombay. And in this cases, the anterior chamber is funnel shaped and deepest in the center and shallow in the periphery. In this picture, we can see iris bombay which has formed. Another change is occlusio pupillae. It occurs when the exudate is more extensive. The exudates organize and across entire pupillary area. A thin fibrous tissue develops in the pupillary area, which blocks the pupil, and it's called as occlusio pupillae. In this image, we can see the occlusio pupillae which has developed. And due to chronic inflammation, the lens doesn't get its nutrition. So there is cataractous changes starts to develop, which is called as complicated cataract. And the pigment epithelium on posterior surface is pulled around a pupillary margin so that patches of pigment on the anterior surface of iris are seen. This is called ectropion uvea, and this is due to contraction of organizing exudates on iris. In the final stages, when there is ciliary body dysfunction, the secretion of aqueous humor gets affected, so IOP falls and eye starts to shrink, and it will go into phthisis. Thank you. The Dr. Soumya will continue the next part.
Good afternoon, everyone. I'll continue with systemic associations in anterior uveitis. So, anterior uveitis is a window to systemic diseases. It can be due to infectious causes, which includes herpes simplex anterior uveitis, varicella zoster anterior uveitis, tuberculosis, syphilis, and very rarely borreliosis, leprosy, rubella, mumps, Zika, or Ebola. They're very rare and have been reported. The non-infectious causes of anterior uveitis includes HLA-B27 positive spondyloarthropathy. GIA can also cause non-infectious anterior uveitis. Sarcoidosis and Behçet's, though they cause panuveitis, but can rarely slowly present as anterior uveitis. Tubular intestinal nephritis and uveitis, SLE, multiple sclerosis, or drug-induced and lens-induced causes can be associated with anterior uveitis. So the third group is anterior uveitis with no systemic associations. This group contains Fuchs, Forshner-Schwarzmann's, and lens-induced. This is the group which is the majority. The more than 50 to 70% of the cases are actually idiopathic and have no systemic association. So HLA-B27 positive spondyloarthropathy, this entity has four scenarios: ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and spondyloarthropathy with inflammatory bowel diseases, which includes ulcerative colitis and Crohn's disease. Coming to ankylosing spondylitis, patients are generally male in their third to fourth decade, presenting with pain and stiffness in their lower back, and ultimately they develop flexion deformity. The disease causes inflammation and bony ankylosis of the axial skeleton. X-ray of such patients will show obliteration of the joint spaces, and the spine will show bamboo-shaped deformity because of the calcification of the spinal ligament. So all the patients, 25% of them will present as acute anterior uveitis. However, there is no correlation between the severity of disease in eye and joint. Few of them shows chronicity and goes to chronic anterior uveitis. Other features are scleritis, episcleritis, keratitis, and mechanical ptosis. Reiter's disease, the classical triad is urethritis, conjunctivitis, and arthritis. Though conjunctivitis is more common in Reiter's, a small percentage, that is 20%, can have acute anterior uveitis. 75% of these patients are HLA-B27 positive. The mode of infection can be urogenital or can be enteric. Patients present with dysuria, acute migratory oligoarthritis, low back pain because of spondyloarthritis, succinate balanitis, and skin lesions in the palm and sole presenting as keratoderma blennerachia. They can have cervicitis and prostatitis. Eye involvement is more common in the enteric variety, though papillary and follicular conjunctivitis is more common, but 20% can have acute anterior uveitis. Psoriatic arthritis, these patients have psoriatic skin lesions which are well demarcated, raised, silvery scaly patch. They can be psoriatic erythroderma or pustular variety as well. Nail changes can be there, which include spitting, transverse depression, and onycholysis. Arthritis occurs in them, which involves the distal interpharyngeal joint, giving the shape of sausage to fingers, causing sausage fingers. 7% of these patients have anterior uveitis. Other features are conjunctivitis, corneal infiltrates, or secondary organ. Uveitis in juvenile idiopathic arthritis, the prevalence is 1 in 1,000. This is the most common cause of childhood anterior uveitis. The etiology is unknown. It is said that a genetically predisposed individual who gets exposed to certain antigen can develop the disease. How to diagnose JIA? A child who is less than 16-year-old has joint involvement which lasts for at least 6 weeks. Most common cause of morbidity in JIA is chronic anterior uveitis. These patients are actually asymptomatic to present with the eye is white, they don't have much symptoms unless they develop sequelae like strabismus, cataract, or BSK. GIA can be of these 5 types: oligoarticular, polyarticular with rheumatoid factor negative, polyarticular with rheumatoid factor positive, Still's disease, or enthesitis related. So oligoarticular means the joint involvement is less than or equal to 4. This is the most common variety. Knee involvement is common. Females are more predisposed than males. The age of presentation is 2 years. 75% of these patients are ANA positive, and 20% of them will have chronic anterior uveitis. Polyarticular means that the joint involvements are more than or equal to 5 in number. Again, females are more common. 40% are ANA positive, and 5 to 10% will develop chronic anterior uveitis. The RF positive group resembles adult rheumatoid arthritis, and they have low uveitis risk. Still's disease is a variety where, along with the joint involvement, they have other systemic involvement as well, which includes fever, erythematous maculopapular rashes, lymphadenopathy, or hepatomegaly. The female and males both are equally predisposed. This group is NA negative, and hence rarely they have uveitis. Enthesitis related, psoriatic related, or undifferentiated. The first two, enthesitis and psoriatic, are high risk uveitis. The ocular features in GIA, it is chronic, non-granulomatous inflammation. The eye is white, there is no redness. It is bilateral, symmetrical, endothelial dusting is present. AC reaction can vary. It can be very mild to be barely visible till severe enough to masquerade endophthalmitis. Posterior synechia is common. BSK and cataract are common. Other sequelae like glaucoma, CME, ERM can develop. Once complication occurs, subsequent complications should be anticipated irrespective of the treatment. And in GIA, ANA positivity shows increased risk of uveitis. Uveitis and bowel diseases, it can be seen in ulcerative colitis, Crohn's disease, and very rare in Whipple's disease. So ulcerative colitis and Crohn's, which are HLA-B27 positive, are predisposed to uveitis. Ulcerative colitis is idiopathic. It is chronic relapsing. Contiguous ulceration, the bowel mucosa involvement is there, and the involvement is contiguous, unlike Crohn's, which is full thickness and the involvement is patchy. So in ulcerative colitis, the patient is in 20s to 30s years of age. They present with bloody diarrhea, tenesmus, and urgency. 5% of them presents as acute anterior uveitis, and this uveitis coincides with the exacerbation of colitis. Conjunctivitis, episcleritis, and scleritis are other features. Crohn's is again an idiopathic. It is chronic relapsing. The full thickness involvement of the bowel occurs. It is granulomatous. Mutation is seen in CARD15. The patient is again in 20s to 30s, present with diarrhea and perirectal lesions. 12% of them present with uveitis. Uveitis and renal diseases, they are very rare. Tubulointestinal nephritis with uveitis syndrome is an entity seen in adolescent girls. They present with proteinuria, anemia, hypertension, and renal failure. But once they are started with steroids, the renal function returns to normal. Their ocular features are bilateral non-granulomatous anterior uveitis, and they respond well to topical steroids. This is relapsing in nature, and sometimes panuveitis can also occur. Burgess is very rare. In this disease, IgA deposition occurs in mesangium. The patients are in 16 to 35 year age group, presenting with recurrent hematuria and URI. Anterior uveitis is very rare. Sarcoidosis, though it is a cause of panuveitis, but rarely anterior uveitis can also be a presenting feature. It is chronic, idiopathic, and sometimes present with chronic anterior uveitis. Non-caseating granulomatous inflammation occurs. Laufren syndrome is an entity which is acute onset. There is a triad of erythema nodosa, which are the lesions on the shin, hilar lymphadenopathy, and polyarthralgia. It is seen in women. Other features in sarcoidosis include lung features, which is cough and shortness of breath, which occurs due to parenchymal infiltration or fibrosis of the lung. Lymphadenopathy is another feature which is seen in which highly lymphadenopathy is more common. Erythema nodosum are the tender red lesions on shin. Lupus pernio are violaceous lesions which are indurated. Other complications could be meningitis or cranial nerve palsy, arrhythmia or sudden death can occur. So this picture shows the mutton fat KPs seen in granulomatous uveitis, posterior synechia, the angle involvement causing nodules in the angles, and the panuveitis in sarcoidosis. Behçet's disease has a triad which includes recurrent oral ulcer. Recurrent means it should have at least 3 episodes in a year. Genital ulcers and uveitis. It is again idiopathic, HLA-B51 associated. The patients are in 30s age group. A panuveitis which can rarely present as anterior uveitis. The key pathogenesis is vasculitis. 30% of these patients have arthritis. Arthralgia is more common though. Demography is development of these lesions wherever we stroke on the skin. Mortality in Behçet's are due to CVS or CNS complications where aneurysms and thrombosis occurs. Ocular features, they are bilateral, white eye with non-granulomatous anterior uveitis. The hypopyon which is seen in Behçet's are transient and they are mobile. It is more severe in men and can cause relapsing remitting panuveitis. And the cause of visual impairment can be vasculitis. Tuberculosis, again a disease causing panuveitis but can present as anterior uveitis. Primarily it is a disease of lung. Patient presents with cough, expectoration and evening rise of temperature. Other sites where TB can occur are GI tract, abdomen, bone, CNS and lymph nodes. Ocular involvement can occur without clinically overt systemic disease. Chronic granulomatous uveitis with iris nodules and broad-based posterior synechia are seen. This disease is caused by Mycobacterium tuberculosis. Choroidal granuloma is pathognomonic of tuberculosis. These are focal, elevated, dome-shaped lesions. Proper systemic evaluation has to be done in case of suspected ocular TB to find the systemic foci. Mere MON2 positivity and interferon SA positivity does not indicate starting ATT. Only the presence of choroidal granuloma being a pathognomonic lesion we can start ATT in this condition. Syphilis caused by Treponema pallidum is a great masquerader and can be suspected in men having sex with men. 4% of patients with secondary syphilis means when the maculopapular rashes occur in the body can have anterior uveitis. The inflammation can be both granulomatous or non-granulomatous. They are again bilateral. And roseolae are the dilated iris vessels which are seen in this entity which later develops into yellowish nodules. In syphilis uveitic, IOP gets elevated and it is again panuveitis and hence cause chororetinitis, neuroretinitis or optic neuritis. In retinitis, the plaque type lesion of the plaque type retinitic lesion is pathognomonic. Leprosy is a chronic granulomatous condition caused by Mycobacterium leprae. It is chronic low-grade anterior uveitis which is described as plasmoid. Plasmoid means plasma-like because the fibrin component is more in these inflammation. Iris atrophy occurs and also pearls are seen in iris which are immunoglobulin deposits of 0.5 mm in diameter. These are known as Russell bodies. Because the innervation is affected in leprosy, so innervation to dilator pupillae is affected, hence meiosis is seen. Systemic involvement is peripheral neuropathy, Leonie's faces, loss of digits due to sensory neuropathy. HSV anterior uveitis, it can occur with or without keratitis. Features in this is sectoral iris atrophy, elevated IOP, and the KPs are stellate and fine. Herpes zoster anterior uveitis, 50% of them have anterior uveitis of variable severity. They develop 1 to 3 weeks after rash. They cause recurrent anterior uveitis. They are granulomatous in nature. Same like HSV, they cause sectoral iris atrophy and raised IOP. Corneal sensation is decreased. And uveitis has also been reported after herpes zoster virus vaccination, and HZV cause hemorrhagic hypopyon. Coming to Fuchs uveitic syndrome, it has a triad of stellate KPs with very mild AC reaction and no posterior synec. It is also called heterochromic iridocyclitis. The inflammation is chronic and non-granulomatous. It occurs in age group of 40. Cause is unknown, it is idiopathic, but rubella and toxoplasma has been suspected in the pathogenesis. It is unilateral disease, generally asymptomatic, and therefore the patient present first time has blurred vision, which can be due to cataract, PSC, or persistent floater heterochromia. The affected eye is hypochromic because due to inflammation, the atrophy of stroma occurs and that of posterior pigment epithelium occurs. Hence, the affected eye is hypochromic. However, in blue eyes, only if the stromal atrophy occurs and the posterior pigmented layer is spared, in those cases, the affected eye will be hyperchromic. Classically, there is no posterior synec. So a white eye with mild AC cells, less flares, stellate KPs, and the KPs have a diffuse distribution. They're not present only in the arch triangle, but present diffusely. Copious nodule and Russell bodies can be seen. Glaucoma develop in these cases. The mechanisms could be pars formation or angle neovascularization. And because of these angle neovascularization, Amsler sign is seen, which is hyphema following paracentesis. So affected eye being hypochromic, diffuse fine stellate KPs, copious nodule, iris atrophy, PSC, and pars development can be seen in these pictures. Posner-Scholzmann syndrome, also called glaucomatous-cyclitic crisis, a recurrent unilateral acute raised IOP, which can be due to trabeculitis because on gonio the angle is open. The glaucomatous cupping occurs because of raised IOP, however, it is reversible. The anterior uveitis is mild. It presents as redness, blurred vision, and halos around light, few AC cells, fine white central KPs, and posterior synec is not seen again here. Cause can be attributed to CMV and H. pylori seen in young males, and the fellow eye may also be at risk. Lens-induced uveitis, it can be phacogenic uveitis or phacolytic uveitis. Phacogenic uveitis is a type 3 hypersensitivity reaction where antigen-antibody complex develops to the lens protein, which was previously immune privileged. So it can be seen after complicated cataract surgery, trauma, or capsular degeneration in a mature cataract. So the capsular breach has to be present here. The sensitization needs 1 to 14 days to occur. Therefore, it will occur in that time period, that is within 2 weeks of trauma or surgery. The inflammation is granulomatous, anterior uveitis, the mutton fat KPs will be there. IOP elevation will be there, and complications include cystoid macular edema, glaucoma, and ERM. Phacolytic glaucoma is an entity where there is no capsular breach. These lens proteins leak from the microscopic openings. Basically, a liquefied cortical matter seeps out through these microscopic openings. Endothelial precipitates develop, AC cells develops, flare, and hypopyon are seen. This slide shows a list of drugs which can cause uveitis. So, ocular infection with HIV can as such cause uveitis, as well as drugs like rifabutin and cidofovir, which is given in HIV, can otherwise cause drug-induced uveitis. Other drugs are rifabutin, fluoroquinolones, bisphosphonates, sulfonamides, diethyl carbamazepine, OCPs, anti-TNF drugs, vaccines like BCG, influenza, PPD, topical anti-glaucoma drugs like metoprolol, anticholinesterase inhibitors, prostaglandin F2 alpha analogs. Urokinase, cidofovir, and VEGF inhibitors can also cause drug-induced uveitis. Further, Dr. Mosmi will be continuing. Thank you.
Good afternoon, everybody. I'll be discussing regarding the workup and the differentials and the management for anterior uveitis. So, to summarize the epidemiology of anterior uveitis, the most common form is anterior uveitis among all the form of uveitis. And the most common cause of anterior uveitis is idiopathic, around 50 to 70%, with the most common non-infectious inflammatory diseases associated with anterior uveitis are seronegative spondyloarthropathies and JRA. The most common infectious cause is viral uveitis, and it's also important that sometimes etiological differentials of panuveitis often present as only solitary anterior segment involvement. So, coming to the systematic approach to a patient with anterior uveitis, the first and foremost thing to be done is to take a detailed history. First, the onset and the progression of the ocular symptoms, like history of pain, photophobia, redness, lacrimation will be suggestive of anterior uveitis. And usually in acute cases, the visual acuity is not severely affected in anterior uveitis. Other history to be taken are past ocular history of any such recurrent episodes, the previous response to treatment, a detailed systemic history, and also we have to take history of recent pregnancy or any plans of future pregnancy, because especially when we are planning to start immunomodulators. So certain specific history symptoms will be, we have to elicit certain specific symptoms so that we can narrow down the diagnosis differentials in our mind just from the history, like stiff, painful swollen joints, or stiff lower back or back pain while awakening from sleep in the morning. The differentials which we have to keep in mind are JIA, HLA B27 associated disorders, rheumatoid arthritis, SLE, skin rashes, or if there's vitiligo or loss of hair, then VKH, sarcoidosis, SLE, syphilis are the differentials to be kept in mind. Abdominal discomfort, diarrhea, melena, vomiting, inflammatory bowel disease is one of the most common cause for it. Oral ulcers, if it's painless, then Behçet's has to be a differential. Painful and young patients, Ritter's is a common differential. Other symptoms like recurrent nosebleed or recurrent sinusitis, Wegener's granulomatosis is one of the most common cause for it. Genital ulcers and urethritis, prostatitis, the differentials we have to consider are Behçet's, syphilis, Ritter's. Headache, peripheral weakness, paresthesia, Behçet's, VKH, multiple sclerosis are most common differentials. And if there is a history of cough or shortness of breath, then sarcoid, tuberculosis, Wegener's, etc. Now, sometimes physical examination can reveal certain signs, like here in the picture we can see oral ulcers. The patient had painful oral ulcers, and so Behçet's was one of the differentials we kept in mind. Here a patient of psoriasis with a skin lesion, which was examined. Secondly, coming to the ocular examination, a careful anterior and posterior segment examination is important. Now, here also certain specific feature will help us to narrow down our differentials. Like if we note iris atrophy, then herpes simplex and varicella zoster virus related uveitis should be kept in mind, especially sectoral iris atrophy. Band-shaped keratopathy is noted in JRA, sarcoidosis. Heterochromia, as Soumya said, in Fuchs heterochromic iridocyclitis. Elevated IOP is noted in HSV, varicella zoster, Poshner-Schlossman syndrome. Now, hypopene, the differentials are HLA B27 related uveitis, Behçet's, endophthalmitis, as well as certain masquerade syndromes. Iris nodules can be seen in granulomatous lesions like sarcoidosis, tuberculosis, syphilis, leprosy, etc. Now, after a proper history taking, we have to narrow down our diagnosis based on the age, the sex of the patient, systemic history, the laterality of the inflammation, as well as the type of inflammation, whether granulomatous or non-granulomatous. For example, in the age group, in children, the most important differentials are the most common differentials are JRA, Toxocara. In young adults, HLA B27 associated disease, Fuchs heterochromic iridocyclitis. In old age, VKH, herpes zoster ophthalmicus, etc. Among males, ankylosing spondylitis and Ritter's are more common, and in females, rheumatoid arthritis and JRA are common. In granulomatous lesions, the differentials are tuberculosis, sarcoidosis, syphilis, VKH, sympathetic ophthalmia, leprosy, etc. In non-granulomatous, seronegative spondyloarthropathy, Behçet's, traumatic uveitis are most common differentials. Now, complete ocular and systemic symptoms from the history as well as from the signs, we can have a presumptive diagnosis. Now, in order to confirm the diagnosis, the necessary investigations have to be ordered. Before coming to the investigations, we should know when not to investigate the patient for any systemic manifestations. Like if there's a first episode of non-granulomatous uveitis with unrevealing medical history and examination, we need not do a systemic workup. In cases of Fuchs as well as in herpes zoster virus associated uveitis, a systemic workup is not required. Now the investigations which we order, a baseline complete blood count is important, in which an elevated leukocyte count is noted in infectious etiologies. ESR is a non-specific marker of inflammation or infection. Now, when we are suspecting TB, a MONTO is done, though it's a non-specific test. For syphilis, VDRL and TPHA, if we are suspecting ankylosing spondylitis, reactive arthritis, then HLA-B27 has to be ordered. Antinuclear antibodies are can be positive in collagen vascular diseases, SLE. Serum angiotensin converting enzyme is ordered when we are suspecting sarcoidosis, but we have to remember that it can be physiologically elevated in chronic smokers as well as in children. Chest X-ray can reveal calcified hilar lymphadenopathy and sarcoidosis as well as changes in tuberculosis. If we are suspecting ankylosing spondylitis, then a sacroiliac joint X-ray is important. And if any unusual presentation is noted with any high-risk sexual behavior, then Friedot analysis for HIV is also to be ordered. Coming to the diagnostic approach in a case of non-granulomatous anterior uveitis, especially in children, most common cause is GIA, so we can order an anti-nuclear antibodies, and if it's positive, then we can go for the treatment as per GIA. If it's a bilateral case with a renal abnormalities, then we can also order a urine analysis of beta-2 microglobulin, because tubulointerstitial nephritis and uveitis syndrome is common. Bilateral non-granulomatous, as presenting as bilateral non-granulomatous anterior uveitis in children. Other things which we have to order, HLA-B27 antigen. If it's positive, then we will treat as per HLA-B27 uveitis. If it is negative, then we'll look for hypopia and aphthous ulceration, etc. If it's present, then we can order HLA-B51 to rule out Behçet's. If it resolves, then no further workup is required. And if it's recur, then we have to work up as a case of granulomatous uveitis. For a granulomatous uveitis, first we have to exclude Fuchs, and then the first line lab test which we have to order are angiotensin converting enzymes, serum lysozyme, serum calcium, as well as MONTO test. So if serum lysozyme, calcium, and angiotensin converting enzyme is elevated, then a probable diagnosis of sarcoidosis can be made. For a definitive diagnosis, we need to do a chest X-ray or CT scan. Sometimes bronchoalveolar lavage also needed to be done. If there is a MONTO positive or PPD skin test is positive, as well as gamma interferon releasing assay is positive, then also we have a probable diagnosis of tuberculosis. To confirm it, chest X-ray and TB cultures are required. Now coming to the management of anterior uveitis, the mainstay of treatment remains medical management. The general goals are to relieve pain and photophobia, elimination of the inflammation, prevention of structural complications such as synecdoche formation, secondary cataract formation and glaucoma, and preservation or restoration of the good visual function. So in a nutshell, if there is a case of anterior uveitis, first we have to rule out infectious etiologies. If any infectious etiology is found, then we have to treat the specific infection. After ruling out infectious etiology, for non-infectious uveitis, first there will be an acute management phase where steroid is the mainstay of treatment for rapid control of the inflammation, and then a long-term management if required to prevent the further complications. So the important drugs in management of anterior uveitis are corticosteroids in topical formulation, periocular and systemic as and when required. Among cycloplegic short-acting like tropicamide cycles, long-acting homatropin, and immunosuppressants and biologics may be used when there is steroid resistant cases or in steroid sparing as a steroid sparing agent. So corticosteroids are the mainstay of treatment which inhibit both the cyclooxygenase pathways of inflammatory response. The topical formulations which are available are prednisolone acetate, betamethasone, dexamethasone sodium phosphate, fluorometholone, loteprednol, Remixolone and difluprednate, among which difluprednate is one of the most potent steroid, and loteprednate, Remoxolone, fluorometholone are known as soft steroids as they have low, they do not elevate the IOP so much. Therefore, they can be used as steroid in cases where there is too much of steroid responder. So if steroid responder, then use topical NSAIDs in state of steroids or a low potency steroids like Remoxolone or fluorometholone. Indications for periocular steroids in anterior uveitis comprises of severe chronic or recurrent uveitis, and if there is anterior chamber inflammation which is not responding adequately to topical steroids alone. So in a case of anterior uveitis, for mild and moderate inflammation, we start with topical steroids 6 to 8 times per day at regular intervals. We have to monitor the progression, and if we'll think about tapering of steroids when there is documented reduction of the inflammation or at least reduction in 2+ cells in the anterior chamber. So we'll reduce it in weekly basis from 6 to 8 times to 4 times, 3 times, 2 times, and 1 times. We'll also add a short-acting cycloplegic along with it. In cases of severe inflammation, we have to start it half to every 1 hourly for initial few days, and again we have to monitor the progression. If there is a documented reduction in inflammation, then we can taper it. We'll also add a strong cycloplegic and mydriatic to break the posterior synecdoche formation. The indications for systemic steroids in anterior uveitis are patients who are not responding to topical therapy alone, in recurrent cases, bilateral cases, severe inflammation, if there is a component of posterior uveitis associated with anterior component, and associated systemic diseases. Now the suggested guidelines to start systemic steroids are like initial dose is 1 mg per kg per day with a maximum adult oral dose of 60 to 80 mg per day. Now the tapering schedule is like till 40 mg per day, we can decrease it by 10 mg every 1 to 2 weeks. After that, we'll decrease it by 5 mg per day for 1 to 2 weeks. Then we can reduce it more like 2.5 mg every 1 to 2 weeks, then 1 to 2.5 mg every 1 to 4 weeks. We have to monitor the blood pressure, weight, glucose every 3 months. Lipid profile has to be checked annually, and bone density should be done within first 3 months and annually thereafter. Along with systemic corticosteroids, supplemental therapy is essential to prevent osteoporosis. Like calcium and vitamin D supplementation has to be given. Sometimes estrogen and anti-resorptive agents might also be required. So in a nutshell, in a case of anterior uveitis, first we start with topical steroids along with mydriatics and cycloplegics. If it's non-responding, then we can add a subconjunctival periocular steroid. If still it's not responding, then we can start systemic steroids. So cycloplegics we give to relieve pain by immobilizing the iris, to prevent formation of posterior synecdoche which can lead to iris bombay and elevated IOP, and to stabilize the blood aqueous barrier and help prevent further protein leakage. The commonly used cycloplegics are atropine, homatropine, and cyclopentolate. Important thing here is tropicamide phenylephrine cycles are used in acute reaction so that it can prevent the formation of posterior synecdoche and also break the recalcitrant synecdoche. Immunosuppressants are used in anterior uveitis when there is in corticosteroid resistant cases and as a steroid sparing agent. So the absolute guideline for starting immunosuppressive in uveitis are Behçet's disease, sympathetic ophthalmia, and Vogt-Koyanagi-Harada disease. Relative indications are all cases which are unresponsive to maximum steroid therapy. So the complications have already been discussed. So most common complications are glaucoma, complicated cataract formation, band-shaped keratopathy, and cystoid macular edema when there is spillover from the anterior chamber posteriorly. So at last, I will conclude by saying that there are certain clinical trials which are going on so that there is greater viability of the drugs in the anterior chamber as well as to treat chronic anterior uveitis cases. So one such thing is a Acthar gel, which is a ACTH analog, which is acting on the hypothalamic pituitary adrenal axis, which binds to melanocortin receptors and thus stimulates the adrenal cortex to secrete endogenous corticosteroids. So thus it acts as a steroidogenic pathway activator. The route of administration is subcutaneous or intramuscular. It's an FDA approved drug and it has shown efficacy for non-infectious chronic anterior as well as intermediate uveitis. Another thing is iontophoresis. This is a device which has been developed by iGet Pharmaceuticals, where there is a generator and an applicator with the drug product inside, which is placed over the conjunctiva near the limbus, and this is an electrode which is placed on the forehead. So the generator will be generate an electrical field in this applicator, and an opposite charge will be there in the electrode. So electrical stimulation will be formed, and during that electrical stimulation, drug will be propelled inside the anterior chamber. The therapeutic agent which is used is EGP 437, which comprises of 40 mg per liter dexamethasone phosphate, and it has been used for inflammatory anterior uveitis. It is in phase 3 clinical trial at present. It has greater bioavailability than topical administrations. Thank you, and Dr. Shorya will be concluding.
Good evening, and thank you everyone. I think you have covered the topic quite comprehensively. I'd just like to add that uveitis is a bit like squint. It's confusing, and it's also got a part of medicine in it. So because of the systemic associations, so what we need to do is that we should have a very stepwise approach to actually diagnosing uveitis. So first we have to move in with how they have mentioned that we have to take a good history, and the history comprises of ocular history as well as the systemic history. And once you've taken that, then you have a presumptive diagnosis. So you go in to see the clinical signs with something in your mind that what you probably might expect. Now, once you've gone in with the signs, you should know how to differentiate it from acute red eye. So once you've differentiated with an acute red eye, and you know that this is a uveitis, then you can probably go in and then start looking for specific features of different types of anterior uveitis. So once you've done that, then you can go back to your history and start asking leading questions pertaining to the kind of signs that you've got. And after all of this, taking in the history and science, you come to a presumptive diagnosis in your mind, and then you want to give investigations in accordance to that. And you are not going to write the whole battery of tests, that you are going to just simply write so many tests which are not even required. So once you have got a uveitis, you should know that which type of uveitis it is first, and which are the common etiologies in that type of uveitis. Say if it is an anterior uveitis, which are the common etiologies, and depending upon the signs that you found, that is how you are going to go about the investigation that you're going to write. So then you are going to write the specific investigations, and once you've got to diagnosis, then you can start the management. Now, one thing that I like to mention is that acute anterior uveitis is the most common form of uveitis, and in that, most of the times we find that it is idiopathic. So unless until that you have what you call a specific systemic history pertaining to an etiology, most of the times you might find that these cases are idiopathic, and you might not lead to any systemic association. So once you have come to a diagnosis, the next thing is about how to manage. Corticosteroids and cycloplegics are mainstay, and you should know how to start them, on what frequency, and which ones to use in which situation. So once you started on the steroid, you should also know how to gauge the treatment response. So what is the treatment response? When do you need to start tapering them? So as she has mentioned, once you've seen a response of 2-step down of anterior chamber cells, then you can probably start tapering it. Then you can do it on a weekly basis. Now, if you have an acute episode, then you can probably just thinking of giving topical steroids, and you have a unilateral eye. So then you can probably go in and give these topical drops, and once it is of a limited duration, it is probably suffice. But in cases where they tend to start coming back again after once you started tapering, these cases are recurrent, and even for that matter, the ones who have actually had limited duration but they kind of recur after a period of inactivity, these patients, and the ones which migrate to the other eye as well, these might need a systemic therapy with systemic steroids as well. So in such cases, we might think of systemic steroids. Once these cases come down with the steroid, but we are not able to maintain a period of inactivity even with oral steroids at 5 or 10 milligrams of Visolone, then we probably need to start thinking of some sort of immunosuppression as well with immunomodulators. So this is how you go about with anti-uveitis. Most of the times topical drops are quite suffice for controlling the inflammation, and rarely you might need systemic steroids and also immunosuppression. And now one thing I'd like to add is that you people should know how to see the signs of uveitis. I think Madhu actually did a quite good job of presenting what are signs of uveitis. I would like to stress that you have to see these cells, because these are cells are pathognomic of uveitis and they are the most important signs. So you should know how to give this settings of your what we call slit lamp. So you should, as he mentioned, you should have no filters. You should have maximum magnification, maximum illumination, and you should have a 1 into 1 mm slit. And in that, if you can see cells, and that is also on a good microscope, slit lamp, sorry. And some of those slit lamps do not have very good illuminations. You might miss the cells, and then you take it to an SR or maybe a faculty, and they might say that you've missed the cells. So you should be very careful that you're doing it on a good slit lamp. Okay, so now I think Zakia is asking, do we start topical steroids with topical antibiotics with topical steroids in acute cases? No, we don't actually need to give topical antibiotics unless until we are thinking of an infection, and most of the times we don't have an infectious cause, so that's why we don't need to give a topical antibiotic. So we only give a topical steroid most of the cases. Fuchs generally doesn't have a gender difference as such. Some places might have given a site of a female predilection, but no, it doesn't. Occasional cells is same as 0.5 cells, and they don't actually show activity, so you needn't be very bothered about that. See, whenever we actually dilate a patient, even during dilatation, you might see a few cells which get dispersed in a anterior chamber. So whenever we are dilating patients, and more so in a pseudophacus, we might see these cells, but these cells do not give a sign of activity. No, heterochromia is not exactly a necessary finding to diagnose Fuchs, because it is a progressive thing and it might not actually be present in acute cases, and it develops with chronicity. So if all of you do not have any more questions, then I'll say happy Diwali to all of you, and do take care and don't hurt yourself, and enjoy your Diwali. Okay, thank you very much. Okay. Okay, so there is another question, sorry. So sign of current activity. So cells are sign of current activity, and flare is a sign of chronic activity. So if you have only flare and you do not have cells, it's not a sign of activity. So if you have cells along with it, with the flare, then okay, fine, it's sign of it shows activity, but only flare per se is not sign of activity. Thank you then.